What if the biopsy tool we have used for decades is simply not the best tool anymore? Welcome to This Week in Pulmonary and Critical Care Medicine. This week's episode is very procedure heavy. We have one trial that may change how we think about transbronchial biopsy. We have another trial challenging routine bronchoscopic guidance during tracheostomy. And we finish with a practical review on peri-intubation hemodynamic collapse. The theme is simple. Procedures are not just technical events. The device matters, the patient selection matters, and the physiology matters. The first study is the FROSTBITE-2 randomized clinical trial published in JAMA. The clinical question was straightforward. For bronchoscopic transbronchial lung biopsy, does a 1.1 mm cryoprobe provide a higher diagnostic yield than conventional 2.0 mm forceps? This matters because forceps biopsy is familiar, cheap, and widely available, but it has limitations. Specimens can be small, they can have crush artifact, and even when we reach the lesion, the tissue may not be enough to make a confident diagnosis. The 1.1 mm cryoprobe is different from older, larger cryoprobes. It can pass through the working channel, meaning the bronchoscope can remain in place during sampling. That is important because older cryobiopsy techniques raise safety concerns, especially bleeding and pneumothorax. FROSTBITE-2 was an open-label, outcome assessor-masked, multi-center randomized trial across 9 U.S. academic centers. It included adults scheduled for transbronchial biopsy for lung nodules or masses, lung transplant evaluation, or diffuse parenchymal lung disease. 500 patients were randomized. 250 to cryoprobe, and 250 to forceps. The final primary analysis included 490 patients. The primary outcome was diagnostic yield, assessed by a central pathology core that was masked to biopsy technique. The result favored cryobiopsy. Overall diagnostic yield was 88.6% with cryoprobe compared with 78.8% with forceps. That is an absolute difference of 9.8 percentage points, with a 95% confidence interval from 3.3 to 16.3, and a p-value of 0.003. The signal was strongest in two clinically important groups. For lung nodules or masses, diagnostic yield was 83.2% with cryoprobe versus 70.1% with forceps. For lung transplant, it was 96.0% versus 88.7%. For diffuse parenchymal lung disease, the difference was not statistically significant, but the subgroup was small. The tissue quality data make the result biologically believable. Cryoprobe samples were larger, had more alveolated area, less crush artifact, and better histologic accessibility. The safety results were also reassuring. The composite safety outcome occurred in no patients in the cryoprobe group versus 4 patients in the forceps group. All 6 pneumothoraces occurred in the forceps group and 4 required chest tube placement. There were no significant bleeding events, respiratory failure events, or deaths in either group. But we should not overstate this. This was done in large academic centers, mostly by expert bronchoscopists. The study did not evaluate cost effectiveness, and disposable cryobiopsy equipment is more expensive than forceps. So this is not forceps are dead. It is more specific than that. In experienced hands, for patients undergoing bronchoscopic transbronchial biopsy, especially for lung nodules or transplant evaluation, the 1.1 mm cryoprobe appears to improve diagnostic yield without a clear safety penalty. In practice, this means cryobiopsy is moving from a niche tool to a serious contender as a default sampling method in selected bronchoscopic biopsy cases. But adoption should depend on operator experience, institutional workflow, cost, and complication readiness. The second study is the FIBERTRACH randomized clinical trial, published in Critical Care Medicine. This trial addresses a practice that many ICUs treat as obvious, using fiber optic bronchoscopy during percutaneous dilatational tracheostomy. The logic is attractive. Bronchoscopy lets the operator see the needle enter the trachea. It may help avoid posterior wall injury. It confirms midline puncture. It can detect bleeding or cartilage injury. But there is a problem. A lot of this confidence has been based on physiology, habit, and observational evidence, not randomized trial data. FIBERTRACH randomized 442 critically ill adults undergoing percutaneous dilatational tracheostomy for prolonged mechanical ventilation. Patients were assigned to endoscopic guided PDT or non-endoscopic guided PDT. Importantly, this was not a trial of high-risk anatomy. Patients with morbid obesity, short neck, difficult airway, limited neck extension, aberrant vascular anatomy, neck deformity, major coagulopathy, or high oxygen requirements were excluded. That detail is critical. This was a trial of routine cases performed by experienced teams. The primary endpoint was perioperative complications. The result? No significant reduction in complications with bronchoscopic guidance. Complications occurred in 11.3% of the endoscopic guided group and 13.1% of the non-endoscopic guided group. Major complications occurred in 1.3% in both groups. Minor complications were also similar, 10.0% versus 11.8%. The most common complication was minor bleeding, again similar between groups. But bronchoscopy was not physiologically neutral. Peak inspiratory pressure during the procedure was higher with endoscopic guidance, 47.4 versus 37.05 centimeters of water. PaCO2 after the procedure was also higher, 44.3 versus 41.5 millimeters of mercury. pH was slightly lower. The editorial that accompanied this trial framed the issue well. FIBERTRACH does not mean bronchoscopy has no value. It means routine use in non-high-risk patients by experienced teams did not show a demonstrable complication reduction. The limitation is also important. This was a superiority trial. It was not designed to prove non-inferiority or equivalence. That distinction matters enormously. The study asked whether routine bronchoscopic guidance was better than landmark-guided tracheostomy at reducing complications. It failed to show that superiority. But failure to prove superiority is not the same as proving the two approaches are truly equivalent. Those are different scientific questions requiring different trial designs, different statistical assumptions, and predefined margins for what would count as acceptably similar. In other words, this trial supports the idea that routine bronchoscopy may not provide a clear additional benefit in standard risk patients managed by experienced teams, but it does not definitively prove that bronchoscopy has no value or that the two strategies are interchangeable in all settings. That distinction is extremely important because negative trials are often overinterpreted. No statistically significant difference should never automatically be translated into these approaches are the same. It also grouped different complications into a composite outcome, which may dilute rare but serious injuries that bronchoscopy is theoretically meant to prevent. So the wrong conclusion would be, stop using bronchoscopy for tracheostomy. The better conclusion is, stop using it reflexively. In high-risk anatomy, difficult airway, morbid obesity, distorted landmarks, or during the learning curve, bronchoscopy may still be very reasonable. But in routine patients with experienced operators, this trial supports selective rather than automatic use. The third article is a narrative review in the Journal of Intensive Care on the hemodynamics of tracheal intubation in critically ill patients. This is probably the most clinically relevant paper of the week for anyone working in the ICU, because the core message is this: intubation itself is often not what kills the patient. The physiology around intubation does, and that changes how we should think about airway management in critically ill patients. The review starts with the intube data, which should honestly make every intensivist pause. In critically ill patients, more than 42% of intubations were complicated by cardiovascular instability, 9.3% by severe hypoxemia, and over 3% by cardiac arrest. That means ICU intubation is fundamentally different from elective operating room intubation. The paper introduces the concept of the physiologically difficult airway. This is an important distinction. We usually think about difficult airways anatomically: limited mouth opening, obesity, cervical immobility, distorted anatomy. But many ICU patients have a different problem. The tube may go in easily, yet the patient crashes because the physiology cannot tolerate the process. And the review frames intubation as a timeline of cumulative physiologic insults rather than one isolated event. That framing is extremely useful clinically. The first phase is the pre-induction state. Many critically ill patients appear stable, but they are actually surviving on adrenergic compensation. They are tachycardic, vasoconstricted, and catecholamine dependent. Their blood pressure may look acceptable, but it is being maintained by endogenous stress hormones. This is why a patient can go from stable to peri-arrest within 60 seconds of induction. The review makes an important point here. In the operating room, anesthesiologists often try to blunt the sympathetic surge during laryngoscopy because it can trigger hypertension or ischemia. But in the ICU, that adrenergic surge may actually be the patient's last compensatory mechanism maintaining perfusion. That is a profound physiologic difference between elective anesthesia and critical care airway management. Then comes induction. The paper reviews the hemodynamic profiles of induction agents. Propofol causes vasodilation and myocardial depression and was identified in prior studies as an independent risk factor for peri-intubation cardiovascular collapse. Ketamine and etomidate generally provide better hemodynamic tolerance, but the review also emphasizes that ketamine is not magically hemodynamically neutral. In catecholamine-depleted shock states, ketamine's direct myocardial depressant effects may become unmasked. That nuance matters because many clinicians oversimplify induction drug selection. The review also highlights something we often underestimate. Apnea itself is a cardiovascular event. During apnea, oxygen saturation falls, CO2 rises, pH falls, myocardial contractility worsens, pulmonary vascular resistance rises, and arrhythmia risk increases. And this becomes especially dangerous in patients with right ventricular dysfunction. The RV discussion is one of the strongest parts of the review. Patients with ARDS, pulmonary embolism, severe hypoxic vasoconstriction, pulmonary hypertension, or microthrombotic disease may already have a stressed right ventricle before intubation. Then, positive pressure ventilation suddenly increases intrathoracic pressure, reduces venous return, and raises RV afterload even further. That combination can precipitate abrupt RV failure and circulatory collapse. This is why some patients arrest after successful tube placement. The tube placement was technically successful. The physiology failed. The paper repeatedly emphasizes that positive pressure ventilation is not benign. When a spontaneously breathing patient generates negative intrathoracic pressure, venous return improves. Once we induce paralysis and initiate positive pressure ventilation, that physiology reverses. Venous return falls, preload falls, RV afterload may rise, and then clinicians sometimes worsen the situation by immediately applying high PEEP to a preload-dependent patient. The review recommends cautious initial ventilator settings with gradual PEEP titration while hemodynamics stabilize. The pre-oxygenation section is also clinically practical. Non-invasive ventilation appears superior to face mask oxygen and probably superior to high-flow nasal cannula for many severely hypoxemic ICU patients because it provides recruitment and PEEP before induction. High-flow nasal cannula may still help during apneic oxygenation. Another major teaching point is fluids. The review strongly pushes back against the reflexive give a liter before intubation approach. Instead, it emphasizes individualized assessment of both fluid responsiveness and fluid tolerance. That distinction is critical. A patient may be preload responsive, but unable to tolerate more fluid because of pulmonary edema or RV overload. The review also supports early vasopressor preparation rather than waiting reactively for profound hypotension. And honestly, this is where many ICU intubations fail operationally. The airway setup is perfect, the laryngoscopy is perfect, but nobody prepared the physiology. No vasopressor running, no preload assessment, no RV assessment, no hemodynamic plan after induction. The accompanied figure frames airway management as a sequence: pre-induction optimization, induction planning, apnea management, transition to positive pressure, and post-intubation stabilization. That is how ICU intubation should be taught, not merely as, can you get the tube in, but can the patient survive the transition? This week's episode had a common thread. First, the biopsy device matters. In FROSTBITE-2, the 1.1 millimeter cryoprobe improved diagnostic yield compared with Forceps. Second, procedural habits deserve to be tested. In FIBERTRACH, routine bronchoscopy during percutaneous tracheostomy did not reduce complications in selected low-risk patients. And third, ICU intubation is not just about securing the airway. It is a hemodynamic stress test, and the crash often begins before the tube passes the cords. If you found this useful, subscribe and share it with a colleague who does bronchoscopy, tracheostomy, or ICU airway management. Until I see you again next week, this is Dr. Aladdin Sagar signing off.